Good evening, everybody. We are together today to discuss about navigating the nutritional journey of patients with head and neck cancer. So I'm Pierre Senesse. I'm gastroenterologist by training, and I'm currently in charge of coordinating the support and palliative care team. I'm working in Montpellier Cancer Institute in France. I'm also the head of the clinical nutrition unit, which includes an adult parenteral nutrition center for the entire Occitanie province. My disclosures, especially for this presentation, I have deliberately not used any product names and therefore have no conflict of interest. The presentation will be in two parts. First one, the curative treatment, and the part two, the chronic illness. So the most important is to define main goals when we discuss about a subject. Here, this is curative treatment. And what about the main goals for these patients? This is disease-free survival and overall survival. So the question is, how can cancer treatment be optimized without the patient's nutrition being detrimental? So to answer this question, we need to specify the treatment principles for head and neck cancer with curative intent. The first information we need to have concern anatomy. And you can see on the top, this is sagittal CT scan slice. And above the CT scan slice for coronal coronal CT scan slice also. And the anatomy is very important here because you have two major locations. The first one is oral cavity and oropharynx, and the second one is larynx. So the oral cavity and oropharynx, this is the main topic we have here in the anatomy. The mucosa of the tongue with its papillae is particularly sensitive of radiotherapy. We'll see after. And the occurrence of mouth ulcers used during treatment cause pain. Also, we have the salivary glands around and the temporomandibular joints that could be impacted by the treatment. And along the neck, of course, we have nose area. And you can see here a lot of difficulties we can have, also dental problems. Of course, we need to address any dental issues before starting the treatment. The second important way is also the specificities of treatment. You have on the left the radiotherapy area is almost really important, and on the right the different combinations of treatments you can have. So on the left, the dose of radiotherapy is conventional and about 2 gray per fraction, and we have 5 fractions by week and about 6 weeks and a half on treatment. And of course, it's not the same side effects. If you include oral cavity here with a red line, oral cavity and oropharynx, and yellow line, if you have the larynx inside, is of course not the same side effects. You know that probably, and also the area could be important is for some patients, or very little or small in other cases. The combination of treatments, apologize, I have forgot one. This is radiotherapy alone, of course, but you can have chemoradiotherapy, concomitant chemoradiotherapy, I mean, surgery alone, or surgery and radiotherapy adjuvant, or also surgery and chemoradiotherapy, concurrent chemoradiotherapy adjuvant, or also neoadjuvant chemotherapy and chemoradiotherapy, and optional now immunotherapy. So we have a lot of treatment with different side effects. To understand what we discuss about side effects, you need to have a little bit information about what are side effects. So I put here two definitions, but we have a book about common terminology criteria for adverse events that is, I think we have more than 100 pages inside. So with all side effects here, I put two. It is oral mucositis and pharyngeal mucositis. This is the most important we can have for head and neck cancer patients and treatments. And for the red lines is the most important part we have. And this is the severe acute side effects. We are really interested by that. We have grade 3 or 4 side effects. That mean for patients, severe pain, and often we need to prescribe morphine. And also you have, of course, this pain interfere with oral intake, with patients unable to aliment or hydrate orally for these patients. So now we could discuss the combination of treatments. We have side effects, we know the definition, we know the anatomy, we know different treatment, we could understand what are the different problems we can have. So this is specificities of side effects. You have two tables here. On the left, this is side effects, severe, grade 3 or higher, toxicities by treatment modalities that not concern location. This is treatment modalities, radiotherapy or chemoradiotherapy. And you can see here mucositis or dysphagia. Look the percent of patients you can of severe side effects you can have. In case of radiotherapy, mucositis is about 50% of patients and 40% for dysphagia. And in case of concomitant chemotherapy, you have 80% of 70% of patients with severe side effects. Just concern treatment modalities. On the right, you have here a table with 3 major publications. This is 3 randomized phase 3 studies published on Lancet and New England Journal of Medicine. The first one concerns chemotherapy, only chemotherapy for patients. It's cetuximab versus, I can remember, cisplatin, I think. But doesn't matter, the drug. The idea here is to look for acute severe toxicities by location. Look for the first publication. We have here 100 patients with tumor of oral cavity and oropharynx, and no patients with tumor or hypopharynx or larynx, and the mean of acute toxicities on average is about 80%, is huge with several toxicities. If we look for the two other publications, published on New England Journal of Medicine, this is the history publications about surgery, then concomitant chemoradiotherapy, published by an American team, Cooper, and Switzerland team, Bernier. You can see here the location of tumor. You have about 70% of patients with tumor of oral cavity and oropharynx for Cooper, and only 30% of patients with hypopharynx and larynx. And you can see the toxicity is very huge. 77% of patients with severe toxicity, grade 3 or 4, with pain, unable to eat. And if you look for Bernier, you have less tumor of oral cavity and oropharynx, about 56%, and toxicity is about 41%. You can see so different that it's really difficult to it's important to understand that we have location and you have treatment, and you need to understand that. So also, just an idea we need to include, we have few information in publication about that. This is why I put my personal experience. Duration of severe acute toxicities between radiotherapy alone compared to concomitant chemoradiotherapy. You have on average 3 weeks versus 2 months on severe acute toxicity grade 3 or 4. So this is very, very important to discuss with patients about that. This is what I say on this. Could I resume something here? If radiotherapy includes the oral and oropharyngeal cavity and is concomitant with chemotherapy, therefore, about 80% of patients will have severe difficulty eating or evaluation, likely from the second cycle of chemotherapy and for approximately 2 months. This is independently of the nutritional status. I mean, I don't discuss about malnutrition or not. This is a treatment, the effect of location and treatment. So now, could you please think about these 2 questions? Because your clinicians, your dietitian, your physicians, you have now this information. You can probably think about this guy is a little bit dumb, perhaps, why not? But if you look for publication, if you have patients with concomitant chemoradiotherapy, you have this information. So what information do you give the patient before treating them? Do you inform the patient or not? And the second question is, how do you plan to manage their oncologic and nutritional care? So we have guidelines. Hope we have the information in guidelines. Surprise, we don't find nothing or very few information in guidelines. The major international guidelines, ASCO, ESMO, ESPEN, European, American, don't mention the feasibility of oncological treatments based on the use or non-use of nutritional support, or even according to the type of support. The French guidelines, which are somewhat outdated now, this was in 2012, and more recently the Australian guidelines note tube feeding may reduce unplanned hospital admissions and reduce disruptions to treatment compared to oral intake alone. So the main idea of clinical nutrition is to enable the implementation of oncological treatment. This is really important to have the information. Don't forget the main goals: disease-free survival and overall survival. And also, nutrition must not interfere with cancer treatment. So you have to close your eyes and to think about patients and chemoradiotherapy concomitant. What about the best for the patient during the treatment? So here, this is a practical algorithm or decision tree. I don't know how you name this, used in my institution for head and neck cancer patients. And the main question is, the patient will have or not, what is the treatment for the patient? Concomitant chemoradiotherapy first, this is the first question, yes or no. And if the answer is no, you have radiotherapy or no alone, yes or no. If it's no, this is surgery or chemotherapy. If it's surgery, you have perioperative guidelines. We don't discuss that today, but if you have questions, I can give an answer. If you have chemotherapy, you don't have systematic nutritional support. But if you have radiotherapy alone, you need to have dietary counseling. Since the publication from Ravasco from Portugal, you have dietary counseling and weekly follow-up. Nasogastric probe, if dietary counseling is insufficient, is proposed. But the most important here is if yes, at the concomitant radiotherapy. And the second question is, radiotherapy, including oral cavity and oropharynx, yes or no? If yes, in my institution, we propose systematically a gastrostomy before treatment, and this is since 2000. And if no, in this case, we need to define malnourished or non-malnourished patients. Apologize here. This is a mistake because at the beginning we put cachexia in this slide, but since ESMO publication in 2021, cachexia is defined by malnutrition and inflammation. And here the decision is not in link with inflammation, but only with malnutrition. We'll see after the definition of malnutrition. And if you have malnutrition, yes, you insert big gastrostomy before the treatment. So here, so recently we reassessed our practices through a retrospective study in an observational research protocol on trismus. We have a protocol on trismus, and the protocol is, you can see the protocol, the complete protocol on, this is a number clinical trial you have here. So you can look on clinicaltrial.gov and you can see the protocol in detail. And the protocol includes adult patients with squamous cell carcinoma of oral cavity and oropharynx or nasopharynx carcinoma. And the treatment is radiotherapy, including oral cavity and oropharynx and concomitant chemotherapy. So in this protocol, we look for our practices concerning nutritional treatment. This is the patient characteristics. We included 45 patients inside. The age was 61 at mean, and this is the median, apologize. You have location, the most important here, this is location. You have 93% of patients with oral cavity or oropharynx tumor, and a few patients with cavum tumor, and nothing more interesting. Slide after. Nutrition, this is the most important now. Before treatment, gastrostomy was inserted for 96% of patients. This is a systematic pathway for patients. If you have concomitant radiotherapy, including, you have gastrostomy, we look for the algorithm and we have results here. We did that just last year. The median time before was, you can see for malnourished and non-malnourished patients, we have a part of patients malnourished, about 26% of patients, but the majority were non-malnourished. About 70% of patients were non-malnourished. Only 2 patients refused gastrostomy, so 1 refusal and 1 contraindication with parenteral nutrition. At the end of this was at the beginning, before concomitant chemoradiotherapy. At the end of the follow-up, how many patients used enteral nutrition? About 90% of patients used enteral nutrition. For how long? But mean duration is about 6 to 7 months of enteral nutrition. And if you are malnourished, of course, this is 10 months. If you are non-malnourished, this is about 3 months. It's huge. And the beginning is about after the second line of chemotherapy during the treatment with chemoradiotherapy. This is about after the second line, just after the second line of chemotherapy. Most interesting, it's gastrostomy. We look for information about complication we could have with nutritional care. It's really interesting to know that major complications occurred for 2 patients with prophylactic gastrostomy before concomitant chemoradiotherapy, infection and mislocation. I think we have a good experience about gastrostomy. We are only 3 operators, and we insert about 150 gastrostomies per year, and it's not too bad. And we look for 2 complications before concomitant chemoradiotherapy. So what about if we have these complications during concomitant chemotherapy? I think we stop systematically chemotherapy. And if we stop chemotherapy, but the main goal is not, we cannot have the main goal. The patient overall survival could decrease. You have less chemotherapy, and of course, this is not good for the patient. Look for the emergency hospital admissions. 14 emergency hospital admissions, 12 patients were observed, none related to enteral nutrition or gastrostomia. I mean, during treatment, of course. And for the 2 patients without prophylactic gastrostomy, what about these patients? 1 week emergency hospitalization was necessary for the patient who initially refused due to nutritional and dehydration problems, leading to the insertion of a gastrostomy. And the second patient with parenteral nutrition required 1 week hospitalization for decompensation of diabetes related to parenteral nutrition. And 1 week after, we identify an infection on central device. So remember, nutrition should aid the cancer treatment, not interfere with it. This is really important. Nobody discusses about that. And this is the most important for this patient. Patients, sorry. If you have doubt, this is the paper we discussed before, the paper that compare cisplatin versus cetuximab, a phase 3 study published on Lancet in 2019. In this paper, you cannot find any word about gastrostomy. It's interesting, except stratification. You have to distribute an equitable distribution in each arm about criteria you define, and in this criteria you include planned gastrostomy insertion before treatment. And what surprise! How many patients receive gastrostomia before treatment? There is 66% of patients in each arm received before treatment a gastrostomia. But it's interesting to have. We don't have really very good randomized study, but when you use gastrostomia before, never you come back after. So this is this is a conclusion for the first part. I would here simply like to emphasize certain part of this slide. The most important, I think, this is when you have a concomitant chemoradiotherapy and a radiotherapy including oral cavity and oropharynx, please insert a gastrostomy before treatment. You can have enteral nutrition or not, but you have to insert gastrostomy before treatment. You could, if your choice is not to do that, or if you cannot, please don't use parenteral nutrition and don't insert gastrostomy during the treatment. Anticipate side effects. The second part now, we move to the chronic illness. In the chronic illness, I mean local recurrence of the disease. After you treat the patient, you treat with concomitant chemoradiotherapy. So the prognosis, you can have surgery and concomitant radiotherapy, but the prognosis is not really good, and you have often local recurrence or metastatic disease, and we need to discuss about that. What about the main goals in case of chronic illness? This is you can discuss overall survival. Oncologists discuss systematically overall survival, and patients also discuss about well-being and quality of life. This is most important, perhaps. Radiation therapy has been completed. There will be no further radiation therapy. In general, no hope for curing the disease. This is just the disease you have, and you pass away by the disease. Oncologic treatment are based on chemotherapy and immunotherapy. Here, I would like to be a little provocative. And I said here, fat is life, and the toxicities are in the muscle. Is it right or is it not right? We'll see. So this is the new definition since 2019, published by an international expert group entitled GLIM, that define now malnutrition. To define malnutrition, now we need to have two criteria, one phenotypic criteria and an etiologic criteria. Inside of this, we have three criteria you can use for phenotypic criteria and two criteria you can use for etiologic criteria. For phenotypic criteria, we need to have weight loss, or this is or inside, this is and outside, phenotypic and etiologic, and this is or inside, but you can have all. Weight loss, so weight loss is I have more than 5% of weight loss within past 6 months, or 10% beyond 6 months. You can have also a low body mass index, under 20 if you have 70 years old, or 22 if you have more than 70 years old. And you have also new criteria we didn't have before concerning Asiatic people, more specific. And you can have also quantify of muscle mass. You can have reduced muscle mass, but for that you need to use some exams like absorptiometry or CT scan or impedancemetry or MRI. All is good for that. You need also to define etiologic criteria, and the most important part here, this is a reduced food intake. This is the first time we see the information about reduced food intake. So we discuss about that after. Also, you can have inflammation, and since ESMO 2021, malnutrition and inflammation associated define cachexia. I think we have, this is my opinion, perhaps a word is missing. It should be better if we define cachexia by malnutrition and chronic inflammation. I didn't see, or I don't see this information in the paper from ESMO, but this is just inflammation. When you treat head and neck cancer, you have high CRP at the beginning with inflammation, and then you treat the patient, CRP disappears, and after, when you have a chronic disease with local recurrence or metastasis, CRP is about every time a little bit high, and this is a chronic inflammation. In my opinion, of course. Now I will discuss fat. Fat is life or not. We have a definition of malnutrition, and we could discuss about BMI and weight loss. This is a publication we did with the Canadian team with Professor Barkos in Edmonton, in the Cross Cancer Institute. This is a publication from Lisa Martin. The title is Diagnosis Criteria for the Classification of Cancer of cancer-associated weight loss. We have a huge population, about 10,000 patients inside, and also a part of head and neck cancer patients. It's very small. This is 1,306 patients with head and neck cancer. And almost the large part of patients is palliative care for this patient with stage 4 cancer. What about results in this paper? The main goal, the aim for this paper is to define survival in regard with weight loss and BMI. BMI defined as fat. You have BMI in the rows, and in column you have weight loss here, since from 0 to more than 15, and also BMI more than 28 and less than 20. You have here clusters. Since COVID, you know that what are clusters, and we have a lot of patients inside. And just in the middle, in the table in the middle, you can see in each cluster, you can see survival by month. And so we can easily understand the difference. So you have 21, on average, 21 months on survival for the cluster for patients, for obese patients without weight loss. And in the opposite side, you have 4 months on survival, overall survival for patients with weight loss and BMI less than 20. If you look for the information in the rows, it's very interesting to see that. You have here patients without weight loss in the first row, and you can see the difference between fat or no fat, obese or non-obese patients. About 8 months on survival on the right, and with obese patients, you have survival about 20 months. If you look for columns, inside the column, you can see for obese patients, for example, if you have weight loss more than 50%, you can see the survival is about 7 months, and the comparison is 3 times more, 21 months for patients without weight loss. It's amazing. You have on the right the specifically curve for head and neck cancer patients, and this is not the color are not on the same, but this is grade A, grade 0 is white in the middle, and the grade 2 is blue, grade 3 brown, and grade 0, 1, 2, 3 gray, and brown, the last 4. And you have the curve here with 0, 1, 2, 3, and 4 here, and you can see the survival, the curve. Look at this curve. You have at 2 years here, you can see the number of patients. The cumulative survival here is here between 90% of patients. And if you look for the grade 4, you have 10% of patients. You look, it's very amazing. So perhaps fat is life. Perhaps is it possible to do that? So we look. Perhaps we could look for patients outside the cancer. So the question is it the same with all chronic diseases? So I look inside for coronary disease or hip fracture or nursing at home. This is huge population, you can see here. The best systematically, if you look for survival, mortality in these cases, systematically the best prognosis is concerned overweight or obese patients. Sometimes even those with morbid obesity, if you look for nursing at home in chronic disease, this last number, this is very small for me also. This is BMI for obese and morbid obesity, obese patients. So don't forget that concern for cancer palliative patients. You cannot have these messages for all patients, and that not concern the general population. Of course, you understand that, I think. And this is only for palliative patients. Oh, this is a question for you I have today. I think it's important to have your answer about this question. And finally, for you, what is the main reason for involuntary weight loss in cancer? You have different lists here, and you need to tick one or one alone, but it's interesting. Well, I could put a lot inside, but just I check a part: pain, depression, side effects, anorexia, food intake, all. So if you have, we have a little bit 1 minute to complete the information, and it's interesting to think about, because I think in this part of palliative care, this is the main information we have to keep with you after the information for the chronic illness. So I'm waiting for your answer, and please, could you complete the question? You are about 400, I think, hope, and we have only 30 votes. So I would just one. Well, I have the answer now. Even I don't have all answers. The answer I have was all for the majority of the audience. This is more than 70%. It's a huge part. Interesting, because it's really interesting, because you saw the answer just before, 3 or 4 slides before, and you don't give the good answer. It's nice. Well, this is not for you. Huh? This is every time. Yeah, this is the same. So it's funny. Yeah, the answer is in this slide. In fact, this is the definition from the GLIM and food intake and malnutrition. And the question is, I remember the question. Remember your question. What is the main reason for involuntary weight loss in cancer? Weight loss is a definition of malnutrition. And food intake and malnutrition, you can see here, etiology criteria. Etiology criteria mean the cause of the reason why you have weight loss, and the definition of malnutrition. So the main definition of the main cause is reduced food intake. This is the answer I'm waiting. I waited. I explain more of that. It's really important to be clear about that. Please look at this slide, and first of all, no, just I come back. On this slide, I would be sure that everybody is okay about food intake is probably the main cause of malnutrition. I'll show you different etiology criteria. Of course, we have a lot, but at the end, the most important is how many gas you have in your tank, how many gas you have in your car, and the food intake. This is the gas you give, and it's you can have anorexia, pain, doesn't matter. Some patient eat a lot, even you have pain or other problems. Um, how to quickly assess the quantity of reduced food intake? Because food intake is a little bit complicated to define. If you need to calculate with sugar, lipids, protein, it's we are unable to do that in practice, in clinical practice. So I put for you this information. I think verbal analog scale of food is a major tool you can have today with you. You need to use that. You can have your nothing in the pockets, nothing in the hands, and you ask about patients. If you consider that at time when you are in good health, you eat 10 out of 10. How much do you currently eat on a scale from 0 to 10? 0 will mean nothing at all, and 10 as usual. And if you use this scale, your life is completely transformed and is feasible and orally validated for 95% of patients. You have the publications on the bottom. And so if you, the question is, do we have a good correlation between the information about the score and the quantity of energy the patient eat? You have the answer on the left here. More the number is high, more you have energy inside the body, and until 25 or 30 kilocalorie per kilo per day. It's a good correlation. This is a subjective information, but this is a good information and very short to do. Everybody here use this tool, and every day, every time, for every patient. And this information is we published a paper with Canadian and with international cohort, and you can look here for food intake. We look for survival, and when we look for survival, you can see here the major information about food intake. If it's the referee, the normal is 1, of course, and ici reference is 1. And then if you reduce food intake moderately or severely, now you have a bad prognosis, and your survival is less than the patient that eats normally. Of course, we have a lot of etiology criteria for reduced food intake, but at the end, we have reduced food intake. So I cannot, I insert here before treatment and during treatment, but in palliative care, after we don't have after during treatment. This is along the time during treatment and death. So before treatment, you can have physical reasons, psychological, social beliefs you can have also, and during treatment, in addition to pre-existing problem, the side effects add up, and you have taste disorders, smell disorders, xerostomia, nausea, vomiting, mouth ulcers, mucositis, dysphagia, odinophagia, and at the end, reduced food intake and malnutrition. Is it correct for you? Hope you understand that. Now we move after fat and weight loss and food intake. We move to muscles and toxicities. Just first slide on this topic, a definition, please, because a lot of papers use the term sarcopenia. I think, but it's not I think, this is the literature. If you look for guidelines, European guidelines, you can see the definition of sarcopenia. The publication is on age and aging. And the definition is clear. Sarcopenia is muscle strength plus muscle mass. Like you have malnutrition with phenotype criteria plus etiology criteria, for sarcopenia, this is muscle strength plus muscle mass. to be clear. And I will not, this is not the subject of the topic today. I will not give details about that, but just the information here. You can have, for muscle strength, you can do that easily. If you don't have dynamometer, you can use a chair stand, just a chair, and you look for the 5 rises, and you have a chronometer, and adjust on 15 seconds, inferior or equal or superior, and you have the muscle strength. And then you could identify muscle mass, and you can use impedance metry or other CT scan, MRI, blah, blah, blah. If you have only muscle mass, this is muscle mass. This is not sarcopenia. But in the literature, be careful. We have a lot mistake about that. So it doesn't matter. The first paper, huge paper, this is important. This is a paper from Vicky Barakos and her team. This is about muscles and toxicities. At the beginning, it was sarcopenia, but this is not, it's not muscle strength. This is mass. The title was Prevalence and Clinical Implications of Sarcopenic Obesity in Patients with solid tumors of lung. It is lung cancer, gastrointestinal cancer. It was patients included in different studies, and retrospectively, the team integrated CT scan, analyzed CT scan to define muscle mass, and results show that patients with reduced muscle mass had bad prognosis in comparison with patients with normal muscle mass. The question we have now, just to give an answer here, this is: do you think that, just a moment, I come back here. Do you think on this course, the first one on the top is the first one, the good? This is a good prognosis, but in comparison with the general patients we have, is it an exceptional prognosis, or finally this part with very bad prognosis? We have an answer, a part of the answer here. the same study published a paper on insufficient muscle mass, a factor of relative poor prognosis, to concern patients with cachexia. And when you look for BMI, in fact, patients with obese patients had a very good prognosis. But the prognosis is very good because these patients had also good muscle mass. When you have one of this criteria, weight loss or reduced muscle mass or myosteatosis, is fat in mass, the prognosis is the same with other populations. So what about muscle mass? In fact, muscle mass is toxicities. This is biodisponibility of products, of drugs. Reduced muscle mass is associated with dose-limiting toxicity, systematically associated with dose-limiting toxicities. You can see a lot of papers. This is a slide from Vicky Barakos. And you have in yellow the normal muscle mass with dose-limiting toxicities here, and in red, the reduced muscle mass here, and you can see the differences. And if you look for inside for the blood sample and the blood concentration of drug, for this example, this is for sorafenib. In fact, sorafenib is twice as high in the group with reduced muscle mass compared to the group with normal muscle mass. You have here the comparison between reduced and normal, and the difference here, the twice here between reduced and normal muscle mass. I look for the time, and I need to advance. To resume, it's very important to have a resume here before to go to the conclusion progressively. Most important, reduced food intake. This is the clinical origin. I could say that as an expert. I say the clinical origin is reduced food intake. Weight loss, poor prognosis, fat, better prognosis, muscle, but if associated with muscles, muscle mass is biodisponibility, and inflammation and malnutrition is cachexia. We look now in practice in my institution. In fact, for palliative care, what is the treatment? First, we need to screen malnutrition. We don't use NRS or PGHGA. It's too long to use. We use only weight loss and analog scale, 0 to 10. We ask the question, and we ask about weight. We ask about current weight, declared or measured. We ask about height, highest weight over the last 6 months, and automatically we have BMI and percentage of weight loss, and then we have food intake. That's it. Then we have two big ways. The first one is palliative or advanced palliative patients, and second is terminally ill patients. This is no artificial nutrition for terminally ill patients. In case of palliative or advanced palliative patients, we can have no malnutrition, defined on GLIM. This is not dietary counseling, but if you have malnutrition, and this is really important, we integrate here a verbal analog scale under than 8, because if you eat under than 8, you have less than 25 kilocalories per kilo per day. Even you need to have dietary counseling first, and then we discuss after 2 weeks. If you don't have a good way, we discuss about artificial nutrition, but this is a discussion with a multidisciplinary team committee, and we discuss about first enteral nutrition on nasogastric probe first. I give you some information. Do you think I'm right or not? So this is a question. I will just share with you this publication published on JCO, Journal of Clinical Oncology, in 2021. This is a paper from Pekin, and that concerns not head and neck cancer patients, but patients with esophageal cancer with metastatic disease. This is palliative care also. And the patients were, this is phase 3 study, and patients were randomized between early supportive care team or no early supportive care team. And supportive care team included a dietitian and a psychologist. And the main goal was overall survival. It's a huge study. Look for the protocol in detail. I have not a lot of time, but just information for dietitian. The dietitians, the protocol was, in case of good nutritional status, dietary advice without delaying chemotherapy was done. In case of moderate nutrition, in this study, this is PGHGA. This is why you have good, moderate, or severe. But in case of moderate malnutrition, dietary advice, and overall survival without delaying chemotherapy, this is not overall, this is oral supplementation. Apologize. This is oral supplementation. And in case of severe malnutrition, this is enteral nutrition. And you can delay chemotherapy in this case. And you have also a huge protocol for psychologists. Local results, fantastic. The main goal is done early. I can see the curve. Early supportive care, overall survival is 14.8 months. And standard care without early supportive care is about 12 months. And this is a significant difference on overall survival. See, it's fantastic with dietitians and clinical nutrition. So, some practical aspects. You have. I saw different questions about that. First of all, I would to say, nutrition is not an emergency. Be careful. This is first. Sometimes you have to wait a little bit, and first you treat hydration or different vitamins, or also renutrition syndrome. Hydration is about 30 milliliters per kilo. The water intake from oral supplements on enteral nutrition accounts for 80%. Energy requirement in case of palliative care, this is 30 kilocalories per kilo per day and 25 kilocalories per day in case of surgery. For obese patients, I give you a formula you can see after. Oral nutrition supplements should be taken between meals as a snack. If you have difficult to give that, you can mix. We use that in the team. We mix one oral nutritional supplement juice in 1 liter of water and use it for hydration. In case of enteral nutrition, you have to insert a nasogastric probe if you need, but every time less or equal than 10 French, no more. If you have a doubt, you have it here. If you have a doubt, you need to try yourself. Everybody here in the team try each nasogastric probe before to propose to other patients. If you have a gastrostomia, be careful. Use an introducer technique because you decrease the risk of parietal metastasis. This information is for head and neck cancer patients, of course. In practice, you complete what the patient cannot eat without exceeding 1 liter per night to avoid reflux. Use mainly iso or hypercaloric nutrients and complete enteral nutrition with an oral supplementation through the probe if necessary, and train patients and all caregivers to do all themselves at home. Conclusion, 2 slides. Clinical nutrition must evolve. Weight loss is necessary, but for the diagnosis of malnutrition. The treatment is not based on weight. How we talk about weight, it's interesting. We discussed about 1 hour. And in fact, this is just the diagnosis of malnutrition. I don't discuss about weight. Why? Because it's necessary to anticipate. 1, to start nutritional treatment as soon as the intake decreases. And 2, to anticipate the side effects of treatments. Can we do this alone? No, of course not. You can see the etiology criteria. You have psychological difficulties. Remember the study from Pekin. Social and financial problem. To avoid beliefs and addiction, for example. How? Perhaps by changing our organizations to work together for all the patients who need it. I will just put for you the last slide. I think this is really important to think about that. This is a paper published by Eduardo Bruera from Edmonton, and this is a coordinator of supportive and palliative care in MD Anderson, Texas. But this guy is born in Edmonton. The discussion is for palliative care first. In fact, you have 3 different models of care. You have the solo practice model, you're oncologist, and you treat all. However, the lack of time and expertise means that these issues may not be managed adequately. In case of, you can use Congress practice model. We have here in France, we have a champion for that. The oncologist refers the patient to various specialties for all the supportive care issues. This could result in fragmented, expensive care. And you can have also the last one. This is integrated care model. And the concept was done for palliative care first. And now here we have open since 2021, we have opened a unit for outpatients, and we included supportive care at the beginning for all patients, and also including, of course, palliative care. And this is what I think my presentation is done. Do you have questions? We have a few time. Oh, I have a question. For creative intent patients, what is your criteria for starting enteral nutrition? Oh, this is, we just, when you have, you eat, usually, And if you eat just in the middle, we integrate enteral nutrition. Or if you have the gastrostomia, we insert the gastrostomia at the beginning of reduced food intake. If you have 8 or if you have 7 on the scale, we integrate immediately enteral nutrition, because in fact during the chemoradiotherapy, you don't have the patient will decrease the general status of the patient is decreased along the treatment, in fact. Is it the food intake or the weight loss? Food intake. You have the answer now. What level of protein do you recommend for further prevent muscle loss? Oh yeah, Daniela said, Professor, can you say that the other questions will be addressed after the session by email? Of course, I can give answer at everybody by email without any problem. So I have a lot of questions, though I cannot. I can to try answer. What level of protein do you recommend? This is you have the information in guidelines said between 1.2 and from 1.2 to 1.5. But in the protocol from China, it was 1.0 to 1.5. What are the nutritional properties would you recommend for enteral nutrition formula? I said this is isocaloric or hypercaloric formula, basic. In this case, of head and neck cancer patients. Oh, this muscle mass. The other question was how much of the reduction in muscle mass is attributed to poor nutrition or high levels of nutrition? Oh yes, I was very happy to be with you, and of course, you can send all questions on my by email, and I try to do my best to give you the best answers. Of course. Bye bye to the audience.